Terrific. Again, welcome to today's program. We're excited that y'all have joined us. Again, thanks to Veracyte-Decipher for putting on today's program. We are going to be touching on personalizing hormone therapy with radiotherapy and prostate cancer, how to use prognostic biomarkers. And we're extremely pleased to have two speakers with us today. And I'm going to introduce them both and then start the program formally. So first we have Dr. Daniel Spratt, who is the Vincent K. Smith Chair of the Department of Radiation Oncology at University Hospitals Seidman Cancer Center and a professor and chair of radiation oncology at Case Western Reserve University School of Medicine. He runs an NIH-funded translational research team focused on the development and validation of prognostic and predictive biomarkers and has published over 350 peer-reviewed manuscripts. In addition to Dr. Spratt, we also have Dr. Alexander Engelman with us. Dr. Engelman is a native of Tampa and currently practices at the Cancer Center of South Tampa. He's a radiation oncologist with experience in treating all cancer sites, board certified in radiation oncology, and is a diplomat of the American Board of Radiology. So we wanted to thank both of you for being here with us today. We look forward to your presentation. And Dr. Spratt, we'll turn it over to you to share your screen and begin your presentation.
Okay, great. Thank you guys so much. Let me move this. There we go. Thank you so much for the invitation to speak today. So just to dive right in here, these are conflicts of interest, and I think sort of importantly, I don't take payments from any of these biomarker companies. So this content, they didn't get to control. And so I think just as, it's an important point. And okay, perfect. So just a background, and I think it's relevant. And so the first half of the talk, it'll get a little bit nerdy and nuanced into some biostatistics, but I think it's super, super important because it really frames the whole purpose to understand how to personalize treatment for patients and use these tests. But, why do we treat patients, to start off with? And it's really to improve the way patients experience life. And, that's really up to the patient to decide their values, whether that's their quantity of life, how long they're living, or their quality of life, kind of basically how they experience their life. But are we improving the way our patients experience life if the quote unquote benefit that we provide them, and that could be in reducing recurrence or reducing a side effect, the patient views this benefit, although we can statistically prove it, as futile to them. And so this is a concept that I've tried to introduce into the literature and presented to the FDA that I've coined prognostic futility. And this concept, I think, will help shape your understanding, but also interpretation of the use of prognostic biomarkers. So you guys have seen slides or pictures like this, right? We take a group of patients and we kind of treat them all the same, even though they're sort of probably molecularly or, whether their life expectancy or the treatment sensitivity or prognosis is different. And how do we get to really personalizing therapy for our patients? And because we don't have this, right, we do not have this, especially in the patients we give radiation therapy to, we by definition have to first accept we overtreat or mistreat the majority, not the minority, the majority of our patients, myself included. And here's just a great simple example, and you could take any clinical trial like this, right? So this was RTOG 9408, the trial of radiation without hormone therapy that my buddy Zach was a co-resident. We spent like 3 days at NRG headquarters to go grab the % positive biopsy cores off path reports to reanalyze this trial. And for patients with unfavorable intermediate risk disease, what you see here is that 70% of patients will never develop metastatic disease out to 20 years who never get hormone therapy. We overtreat them with hormones. 20% are mistreated, right? They are given hormone therapy, but they still develop metastasis. And only about 10% of patients by 20 years out, ADT prevented the development of mets. So you could either focus on this as this is, a p-value that's significant, Or to really focus to share decision making is you may frame this as the absolute benefit. It's 10%, right? So that's a number needed to treat of 10. You treat 10 patients, you prevent one from developing distant mets. Or what we often, I think, are more trained to do is we say, oh, the hazard ratio is about 0.5. So that's a relative benefit of 50%. So as we dive even deeper in here, so, what the heck are we talking about when we talk about prognostic and predictive biomarkers? I'm not even really going to get into predictive biomarkers in this talk, but in essence, all a prognostic biomarker is it's something, and it doesn't need to be some fancy genomic signature that informs you of prognosis irrespective of treatment type. So that's, what AJCC staging is, or risk groups, grading. That is prognostic, right? The worse or higher the stage, the worse the outcomes are. Predictive biomarkers really relate to something that is very specific to a given treatment, okay? So like EGFR mutations and an EGFR inhibitor. But, prognostic, if you've got higher stage, you do worse whether you have hormone therapy, surgery, radiation, you name it, than if you had a lower stage. And so, there's a laundry list of things that we use clinically that are all prognostic biomarkers for various endpoints. And it could be as simple as a PSA or the grade or the age or fancy genomic, test as well. And so this is where I dive just for a moment, a little deeper, just to drill this point home. For prognostic biomarkers, if you were to take two treatments, let's say radiation with and without hormone therapy, that hazard ratio, okay, of the benefit of hormone therapy, which is the relative benefit, is constant regardless of the biomarker score. So whether you have low risk, intermediate risk, high risk, or stage 1, 2, 3, it is prognostic, not predictive, if that relative benefit is the same. So an example, a patient getting radiation alone, 80% chance of metastasis, you give hormone therapy, cuts it in half, 50% relative benefit, you have a monstrous 40% absolute benefit. But if this is a prognostic and not a predictive biomarker, then in a patient with a good prognosis, the black curve is 10% risk of metastasis. That, again, you had hormone therapy, it's cut in half, you have a 5% absolute benefit. So it would be an example, whatever is, whether this is stage 4 patients, stage 1 patients, whatever you're using to determine where these black curves fall, is a prognostic biomarker. What this looks like, this is formatted a little funny, the low, middle, or intermediate and high risk. And this could be, again, stage 1, 2, 3. It could be biomarker score, low, middle, high. You pick your prognostic test. If you were to plot what's the relative benefit of ADT, it'll be about the same for each group. It's prognostic, not predictive. And so if you were to test this in a trial, you would say that there's no interaction, there's no differential relative benefit, there's a similar relative benefit. But so this begs the question, and I heard this, when I was training, as people said, oh, you don't need to give ADT for low risk men, it doesn't benefit them. But here's the actual data, and that this is for biochemical recurrence. There is actually, and they put it in their manuscript in text form, the New England Journal paper, there was no interaction of the benefit for biochemical recurrence of adding ADT to radiation for low, intermediate, high. You can sort of see some maybe subtle trend, but they all benefit very similarly. So why do we not give ADT to low risk men? Well, I'll explain that, because that's when you get to absolute benefit. Because while relative benefit is constant, the absolute benefit changes with the biomarker score, which we already talked about, 40% versus 5%. So we did this, this is the only kind of survey I've done in my career, and I'm sure I messed this up because I'm not a formal survey researcher, but we just wanted to understand, and this gets to this concept of prognostic futility. What is the absolute reduction in distant mets that we surveyed a bunch of NRG GU members? So if you want to call them GU experts, fine, but and well as just on social media, on Twitter, just to see, what is that reduction you would need for you to actually take short-term ADT? And what you see here is, a 1% reduction which is a number needed to treat of 100, all the way to a 10% reduction. And you can appreciate here, the sample size for NRG is tiny, but, the majority of people would not probably take short-term hormone therapy till it's over, 2+% benefit, some over 5%, some over 10%, which probably means they never would take it because no trial has shown a benefit larger than this for intermediate risk. But the point is there is variability. And so this will get to why we don't add hormone therapy for low risk is let's just plot this example here. So you've seen this like in any published trial of in red here, radiation alone, in blue here, radiation plus hormone therapy. And I'm just making this up, a hazard ratio of 0.5. So a 50% relative benefit. But let's plot this a different way. So what I've done here is I've said, well, let's take the 10-year cumulative incidence of METs and let's divide it into 10 prognostic groups, low risk to very high risk, stage 1, 2, 3, 4, you name what these 10 groups are, but from favorable to unfavorable prognosis. And what you'll see is that the absolute benefit based on these patients' prognosis is highly different from, over 10% to less than 1%. And so this is why we don't add hormone therapy in low-risk disease, because while the relative benefit is there, the absolute benefit is futile. It's immeasurable. And that's why statistically, especially for endpoints like metastasis, are always not significant because you would need just a massive trial to detect it. And this benefit, if you want to call it that, is futile for probably us and for our patients. Usually, most people would say for hormone therapy, 10% is we definitely should give, and this is where that shared decision making comes in. Some patients want to do everything you can do. Some, they really need a big benefit, and this is where you have to individualize risk. So if you move away from, this is just an example again of taking a whole bunch of prognostic groups, the benefit of hormone therapy, in this case, I made the hazard ratio 0.6, you would conclude if you ran this trial, right, that there is a benefit in low risk all the way to high risk of adding hormone therapy. And it would be concluded if you did a non-inferiority trial that it's not non-inferior because the relative benefit is the same. But what I'm trying to get, and this is this concept of prognostic futility, is if you instead plot absolute benefit here, so this is the risk of metastasis, and you set this threshold wherever you want, this prognostic futility margin, I'm just putting it at about 2%. That for most patients, if you have less than a 2% reduction in METs at 10 years, they'll probably not want to have the therapy. And so even if the relative benefit is still there, it's futile. Okay, so this concept is really important. And I realize it's getting in the weeds here. But let me sort of show you examples of this. So here's a trial of surgery versus nothing, the PIVOT trial. And if you look at, this is basically their metric of metastasis, and there was no interaction by low, intermediate, or high risk patients. If what you do is you split, and I'm just, you think of prognostic groups A through G, favorable to unfavorable, you pick your system. If you look at active surveillance, the risk of METs, you look at surgery, the risk of METs, and you look at the net difference of benefit, you can't see in these favorable patients any probably meaningful benefit to where you would do it. And again, statistically, you need a monstrous trial to even prove this to be significant. But as you get higher and higher into intermediate, high risk, et cetera, that benefit becomes real. And that's why we recommend radical therapy as the risk groups get higher. You look here, this is from a meta-analysis that the MARCAP consortium did of radiation with or without hormone therapy. It took all the trials that have been published in this. Its hazard ratios of about 0.6. There was no interaction or difference by risk group. And again, to just plot the same thing, radiation in orange, radiation plus hormones in yellow. And the net benefit, again, until you start getting sufficiently aggressive disease, many people would say this is futile to add hormone therapy. But the problem we have clinically is how do you get accurate absolute estimates of risk with suboptimal prognostic biomarkers? And NCCN risk groups is basically the core of our prognostic system, which is really crappy. I mean, it's not good. And, there's been a lot of evolution of prognostic systems, and just for the purpose of time, I'm not even going to go into all this evolution, but we fundamentally today, despite lots of advancements around the world today, we fundamentally use, I call it like a 4-tier NCCN system: low risk, RADONCs, like favorable, unfavorable, intermediate, and then we sort of lump all high risk together, and yeah, maybe you subdivide it a little more, but this is still, and Anthony D'Amico made functionally this system in the late 1980s to risk stratify biochemical recurrence. So like, think about what the world was like in the late 1990s. I think it was 1998 when he published the paper. I mean, to what we are now, it's kind of crazy. This is still how we guide treatment. And so what, one of my colleagues, Dr. Dess, that's still at the University of Michigan, great guy, he looked at multiple randomized trials through NRG Oncology, about 10,000 men, to see, well, how good is NCCN and the variables we use to risk stratify our outcomes we talk about in clinic. And so this is a metric of discrimination, meaning that if you took 100 people, how accurately could you identify if they would develop biochemical recurrence or die? A coin flip, right, would be 50% you'd get it right. And Gleason, PSA, T-stage, or NCCN risk group are barely better than a coin flip. But all of us, and well, I shouldn't assume all of you, I have been, and everyone that I work with and speak with has been completely brainwashed that Gleason score is like the holy grail of risk stratification, to the point people actually do trials with Gleason as an endpoint, right? Like, can we reduce adverse pathology? There are very few cancers out there where you can go from like, right, a Gleason 6, we can do nothing, active surveillance, to Gleason 10, you could do external beam, brachytherapy, long-term ADT, and add abiraterone just by the grade alone. It's kind of crazy. And if you look at NCCN guidelines, right, every treatment listed, all the algorithms for localized disease are based on prognostic biomarkers. None are predictive biomarkers. And so when we're thinking about in localized or recurrent disease, right, when do we observe? When do we add local therapy? When do you intensify or change local therapy, add systemic therapy, intensify systemic therapy? How do you make these decisions? Right now, they're crudely made through NCCN risk groups. And so when we think about, so what do we use in the clinic, right? We use grade, we use MRIs often, and these are, of course, phenotypic. I mean, how many of you have had, your pathologist read something, or an outside pathologist read something, or it's reread and it's changed? So there's a lot of inter-reader variability, even amongst experts. And fundamentally, right, Gleason scoring and PIRADS, right, none of these were designed to be optimally prognostic, right? Dr. Gleason in the 60s wasn't training some fancy model to predict recurrence. He was finding just phenotypes and clusters of patients that look similarly based on what looked like the angriness, aggressiveness of these cells. So it's not even like an optimized model. So we shouldn't, I always say we shouldn't, criticized Dr. Gleason or the Gleason system. It was never trained to be highly prognostic. We have obviously far more objective methods that, take tumor. It doesn't rely on human interpretation. You get, genomic outputs of this. And what seems to be most relevant for prostate cancer is the gene expression, because it's a tumor that has very few mutations. So unlike lung cancer, for example, its transcriptome is highly variable, but its genome is, well, a lot more quiet. And this just sort of paints the picture. This is about 18,000 men with high-risk prostate cancer. So each column here is a patient, and they have high-risk disease. And so you'd think it's homogeneous, but the expression, from low to high, there's vast differences in gene expression. And this is, I don't know, 20 different prognostic gene expression scores from different groups listed here. So there's a lot of heterogeneity that we just simply don't capture by calling it high risk. Now, I'm the first to tell you, and I've helped develop numerous gene expression biomarkers, and many of the ones I've created are absolute garbage. And there's probably thousands out there. But don't just take, just because there's one crappy biomarker or gene expression biomarker doesn't mean all of them are. So I try to say, don't throw the baby out the bathwater. Some have great validation. And the groups, to their credit, have put the work in to make sure it validates, because you really want to make sure that it validates before you use this in clinical practice. This is from the 2023 guidelines, and I'm just showing you the gene expression tests here: Decipher, Polaris, Oncotype. They're all prognostic, none are predictive. And as based upon the Seidman criteria, which is a criteria used to sort of quality or level of evidence, is right. Decipher is the only one with level 1 evidence. Now, I'm not saying that these tests, right, could not gain level 1 evidence in the future, but right now, pretty much the only test that I think has evidence, why I use it in my practice, is Decipher. I guess it's got the most evidence. So these 3 tests out there, just to sort of mention, is, there's the Oncotype test. This is a test that's, predicts adverse pathology. Again, I don't believe that that's actually a clinically meaningful endpoint, because I just showed you Gleason itself is not very prognostic. Unfortunately, it did not reach significance in the only prospective cohort study they ever did. All of the others are retrospective. It didn't meet on multivariable analysis. So it's something that, again, I don't think there's a lot of use in the radiation oncology world. Polaris is made by Myriad. Again, it has level 3 evidence just because there are no prospective trials or post hoc trials that have been analyzed. Bob Dess, who I mentioned, wrote an editorial. One of the challenges in a cohort with radiation patients that came out recently was, the genomic score you order, it has an AUC about what a coin flip was, and what the actual test is when you order it, it's CAPRA, which, think of it as like NCCN risk groups on steroids. It's all clinical pathologic variables that are free, plus the genomics, it's a little bit better. So I don't know. It didn't seem to be that impressive, at least in radiation patients. And then I'll go over just some of the data for Decipher, and there's been 11, importantly, post hoc randomized trials analyzed to date. 1 actual true randomized trial that randomizes to use or not use Decipher, but that's more of a clinical utility study. So these are the studies. Some of them are published, some of them presented. And so in localized, we've got from intermediate through high-risk disease. These are all radiation trials. In the post-op setting, there's 2 trials for salvage radiation therapy. This is that trial I worked on with Dr. Todd Morgan, which is a randomized trial of patients who have surgery plus or minus getting Decipher testing. And we're running, it's not done, called G Major. I think they must love, music, is where in localized disease, randomized to plus or minus getting genomic biomarkers. And then even in the advanced setting, in metastatic hormone sensitive and non-metastatic disease. And so this now is already outdated. We put this out, I think, a year or 2 ago, and it's already outdated. But, there's about 42 studies, and I sort of, obviously many are retrospective, and I sort of highlighted before some of the trial data. But one of the big challenges of prognostic biomarkers, all the companies, right, they give you a test report and they tell you, oh, your risk of mets or recurrence or death or whatever is some percent. But again, most of us haven't been trained to think in absolute risk. And we think about, what does the guideline say? What is an intermediate risk patient? Like, what are we supposed to do for that patient? And so this is, I sometimes say to people, I have a very simple brain in that I said, well, okay, well, all of us think in the terms of NCCN risk groups. That's literally, and probably you need to, right, to defend your decisions to some degree. And I said, well, why don't we simply take these functional, and I sort of always call these the functional 4 NCCN risk groups, and layer on the genomic classifier, the Decipher scores, their pre-specified risk groups. And by simply adding up these scores, you get sort of a new very low to very high risk system, if you like that granularity, or if you want to simplify it back to a 3-tier, you could do that. And what this enabled, and there's been numerous validation studies of this, is that you get these AUCs back in, about 0.85. I think the highest was 0.9, but it's in the 0.8, 0.9 typically It's not perfect, it's not 1.0, but it's a lot more accurate at predicting which patients will develop metastatic disease. And what's relevant is that about 2/3 of patients will be reclassified from your standard NCCN risk groups, right? So you take favorable intermediate, okay? NCCN favorable intermediate. As we know, there's more and more studies coming out. They're talking about, can you do active surveillance on them? Is it safe? Who do we do it on? Well, it's about almost half of these guys, their genomics at least looks like more of a low risk patient. Okay, and that sort of fits clinically, but about half of them do not. They probably, look, more aggressive. Similarly, a lot of unfavorable intermediate, 40% of them look like high risk, and we know that as well, because right, a biopsy of 4+3, you take them to surgery, a non-trivial amount of those are probably just full-on 4+4s, but this enables, right, a little more granularity of pushing patients into a more accurate prognostic group. So of course, so we've got our guideline recommendations. That's what we all sort of are trying to practice by. And I've simplified this immensely, but, for very low risk, I think, active surveillance. For low risk, and this is just me personally, I don't treat them, but I do either a strict, every year, or is it every 3 years, like in Canada, surveillance, favorable intermediate, very selectively active surveillance versus radiation alone, add ADT, add long-term ADT, and now with Stampede data and select patients, maybe add abiraterone. But you can, apply this also with the clinical genomic risk groups, where you can, layer on that genomic test and still give sort of a guideline concordant care. And if you see the newest 2023 edition, and it's voted on, but I wrote the risk stratification section, you'll see now that it actually says in there that with more accurate prognostication, with whatever biomarkers, you believe have evidence to do so, you can change your management to the risk group above or below it, obviously with caution, because it's not some big, robust clinical trial. But NCCN risk groups, it acknowledges right in the guidelines now in that section that is suboptimal at risk stratification, but we use it still because our clinical trials have been conducted and reported in the context of NCCN risk groups. So let's just, in examples here, so let's just say, for me, again, personally, I don't use any biomarkers other than an MRI in very low risk. It's not that there are no patients who could benefit, but it's just something that I think, just keeping them on surveillance, and if it ever gets progression, maybe at that point, if you want to, you could discuss it. In low risk, I think that, if patients want, I discuss the pros and cons of getting genomics is, from music, it's a prospective registry, about 95% of all patients biopsied in the state of Michigan, patients who had Decipher testing and real world use, those, and UCSF has published similar studies, those with high Decipher scores have much more rapid time to coming off active surveillance. And also, even in low risk patients who then get treated, have higher rates of recurrence. And so to me, I probably, when we have this data, I do not favor the clots sort of Q3-year regimen of surveillance. I do the Hopkins every year biopsies for these patients. For intermediate risk, sort of the first study that was done in this was done by Ali Berlin from they had to have this prospective registry at Princess Margaret. So it's not a huge, I think it's 100 some odd patients. Most of the patients were unfavorable intermediate risk, and very importantly, in Canada at the time, they gave no hormone therapy. So all they got was dose escalated radiation. And as you see here in the low genomic risk patients, despite getting no hormone therapy, no man developed metastatic disease in this cohort. So it goes back to that prognostic futility. How the heck can hormone therapy benefit these patients? And we recently got, and these studies take forever, but we got approval through the government to get the samples from RTG-0126, a trial of standard versus dose escalated radiation. And remember, these samples are like, 20 years old. So there's a lot of degradation. And again, what was intermediate risk back then probably is like high risk today, because a lot of the patients, Gleason 7 back then is more like Gleason 8 today. But sort of regardless of that, what you see here is, time to needing salvage therapy. So all the event rates are higher because of the stage and grade migration, but it's 55% if you're Decipher high versus 20% if you're Decipher low. Again, looking at distant mets, again, most of the patients have low risk here, but not all of them. It's 4% at 10 years versus 16%. So this trial used no hormones. Again, are you really, if you added hormone therapy, let's just pretend this is prognostic, it cuts that risk in half. You could lower it to 2% if you're Decipher low, but you could lower it by 8% if you were Decipher high. And this, I'm sorry that it looks so fuzzy. This was just at ESMO. They actually analyzed Stampede, their localized high-risk patients on Stampede of adding abiraterone. If you focus on the right here, those with below the median, which I think was like a Decipher of 0.8 or something, the benefit of adding abiraterone was very small in the lower Decipher patients, but was pretty massive in those with higher Decipher scores. So again, not predictive, but prognostic. And so this is, again, as we're more and more discussing the role of abiraterone, this can be another triage tool to avoid overtreatment. And then, this had changed the NCCN guidelines in the recurrent setting. This is the RTOG 9601 trial, plus or minus 2 years of bicalutamide. Again, this was like 30-year-old tissue. It had like mold growing on it in the biobank, but it's just incredible that you could still get viable RNA. But, low Decipher patients had almost no risk of dying of prostate cancer. And high-risk Decipher, approached almost 40% of them died. And what this is telling you is that in the lower genomic risk patients, even amongst patients with PSAs less than 0.7, adding 2 years of bicalutamide did not improve, reduce metastasis, death from prostate cancer. And again, take this with caution, but they actually had worse survival, and that's probably because this was 2 years of bicalutamide, which has all sorts of side effects. And this was an SAKK trial done in Europe. This was that trial that was dose escalation in the post-op setting, which was a negative trial. But I really like the study because you see here this heterogeneity, even in, not a lot of patients, but even Gleason 910, right? There's patients with low genomic risk with Gleason 910. And you see here the freedom from needing hormone therapy because these guys all got post-operative radiation with no hormones. If you've got a low or intermediate Decipher, very few of these men ever needed to get on hormone therapy. So this work, this sort of clinical genomic risk structure, led because, obviously we always want more data. Who doesn't want more data? So we have helped design it's really 4 randomized trials, but there's one in the unfavorable intermediate setting, NRG GU010, and this is 09 in the high risk setting. But it's essentially just using that prognostic futility margin in that if you've got a lower Decipher score, the hazard ratio will probably be very similar in the low Decipher and the high Decipher. But the absolute benefit we estimate in this low risk subset is going to be less than 2%. Like I think we powered it like 1.8 or something percent, which people felt was futile, and we'll see what it is. And in the higher scores, these patients unfortunately have decently high metastatic rates, adding darolutamide. And the same concept in high risk, going from long-term ADT to 12 months of ADT, or in the high risk, adding a treatment intensification with abiraterone. Actually, they've changed it to be apalutamide now. So the take-home points, almost wrapped up here, is I think nearly all treatment decisions that we do, probably throughout radiation oncology, but definitely in prostate cancer, are based on prognosis. That literally is NCCN risk groups. It's prognostic. I think it's helped me, at least in practice, to really understand this concept of prognostic futility, to understand how to personalize treatment. And this requires understanding absolute risks and not simply, oh, this trial was positive, it had a positive p-value, or it has a relative benefit. But in order to get that confidence, you really need accurate risk stratification to enable using this whole concept. The current standard of care risk stratification in many diseases, but prostate cancer unquestionably is very poor. And I think this is rooted the most in the obsession, and we've just been brainwashed with this concept of Gleason grading being so accurate. And so we end up over-treating, myself included, over and under-treating most of our patients. And so, there are multiple biomarkers out there. The one that I think has, especially for the field of radiation oncology, because it's been tested through so many of our RTOG trials, the Decipher test improves risk stratification. I think that's proven, right? And I think it independently adds information. And, there's been multiple studies, and I didn't go into all of them, that, it does change management. And so to me, the way I use this test, and we'll talk more, after this talk's done, to have that accurate shared decision-making conversation to a patient, is there a benefit to you? It's not that there's no benefit, but it may be so small. So thank you guys so much for the invitation to speak today. And then I feel like it's my new family department, and these were all the 160 people in my department. We got this nice photo made. And so anyways, thank you guys. And look forward to talking with Dr. Engelman and any questions you guys have.
Let me be the first to say, Dan, thank you so much for a great overview and for your contribution.
Thank you. Appreciate it.
I really enjoy the concept of absolute benefit and shared using Decipher or any genomic risk stratifier. We do a lot more of that absolute benefit versus risk calculation in we look at a lot more cardiovascular baseline risk. I start on anyone that we entertain use of ADT on based on cholesterol. Try through some HA, ACVD risk calculator. What is their 10-year risk of cardiovascular disease or stroke? And try to balance their quality of life goals, their life expectancy, and their cardiac risk against the absolute benefit of hormone therapy, that intermediate. And discussing that with colleagues, we concept of consent to ADT came up, and I think of our colleagues have patients sign consent for ADT. I wondered in your practice, besides of course patients, we all consent them therapy.
Hey, Dr. Engelman, I don't know if it's just me. I think you may be breaking up. Is that someone can?
Yeah, no, I think it's for everybody, Dr. Engelman. I think your audio is going in and out a little bit.
All right, I'll switch over. Is this a little bit better for you guys?
Perfect. Yeah. So what I heard was you guys, try to balance all the different pros, cons, cardiovascular risk, try to get estimates, and that you guys or various people, will consent patients to ADT. Was sort of the last thing I heard from you.
Yeah, and I wonder if you use a formal written consent the way we do for radiotherapy for hormone therapy.
Yeah, we do. It came out of, if some of you guys may have Via Oncology at your sites, but I think, yeah, so we both when I was at University of Michigan and here, there's a consent form for ADT. I mean, it's not huge, but there is a consent form to deliver the therapy.
Yeah, I think it should become a little more standard practice.
Yeah.
We have felt comfortable in our folks with minimal unfavorable or even minimal high risk features who do have competing cardiac risk and competing life expectancies, but with very favorable genomic classifier scores omitting hormone therapy. And I wonder your thoughts in terms of someone with true clinical high risk, certainly not very high risk, but a very favorable genomic score. Do you have comfort in omitting ADT in combination with dose-escalated radiation?
Yeah, it's great, great question. I think that I like to think in general I'm on the side of the early adopter, but I think, so plug one is always, and I mean it sincerely, is obviously those two trials I mentioned I encourage people to enroll on, because that's hopefully will just be majorly disruptive to the field if we move that route to really just be, genomically risk stratifying patients. But outside of a trial, I would say that I am fairly comfortable for an unfavorable intermediate risk patient, even if they don't have cardiac disease, if they have a low genomic score. And this is actually this was, yesterday in clinic. Guy was about 70 years old, no real major health problems, Gleason 4+3, but he had a Decipher of 0.35. And just for you guys, if anything below 0.45 is low. And, I said, look, you may benefit from hormone therapy, but, I've got heaps and heaps of trial data, and, my estimated is probably about 1% at 10 years. And we just had a frank talk, and at him and his priorities, his goals, it wasn't worth it to him to have a 1% benefit. And, I don't blame him. I showed you that survey results from all sorts of, GU physicians. For high risk, though, I would say that, I hope to get there someday, but, because long-term hormones, even in guys with, over 70 years old, still improve survival, like 18 over, 6 months, to not do any hormone therapy, I would say, like, unless the patient just refused, I'd be a little more hesitant, especially if that high risk was driven by primarily grade, or other features than just like PSA alone. But I definitely have high risk guys where I drop it down if they won't be on trial to 12 months, some even 6 months if they've got, cardiovascular risk factors, to sort of strike that balance.
We often encounter the situation where we have the intention to proceed to long-term hormone therapy, and during the course there's some side effects or there's some complications, cardiac risk events, what have you. And so we'll commonly revisit their genomic classifier to see, how strongly do we mandate the full duration of therapy versus do we feel comfortable in the face of a very significant quality of life impact or maybe even cardiovascular events, stopping a little short.
Yeah, and the data, it's even in clinical trials, right, where you'd think there'd be the best compliance data out there, or compliance utilization. It's probably 70% plus minus of patients receive, in the trials that use like 36 months, it's like 50% compliance. So I mean, a lot of patients, right, if it's their choice to stop, that's understandable. If you get new data, obviously, like if they have a heart attack or some other event, it sort of shifts that discussion. I sort of on topic, but tangential a bit, what I have found for a lot of patients, assuming insurance covers it, because obviously cost is the layer on top of everything we're talking about that has to be considered, is, the Orgovyx, the Relagolix, the oral ADT agent. And the reason I found patients often like it is they can take it, it's a 1 day, 1 pill a day. And what's nice is, especially patients hesitant to use it, you just say start it and you can stop it, right? It's not like you're giving them a 3-month shot that takes months to recover. And so guys where it's sort of like, oh, you have high risk, or they really don't want to do it, they have unfavorable intermediate, but a high genomic score, they really don't want to do it, that I've had a lot of good luck just starting them on the pills. And most of them have finished the whole course because it gives them that control. And I think that's a big issue with, the 3-month and 6-month ADT shots is, and I understand it. Like, I'd feel like I have no control because you get a 6-month shot and oh my God, I mean, it takes 18 months in total to recover testosterone. Like, you're on for the ride, whether you like it or not.
Yeah, we've enjoyed using it as well. I think you briefly mentioned, but I also enjoy knowing that that Decipher at least is a continuously validated variable, not just categorical. And so in some of those men with more intermediate risk scores who may not have a large absolute benefit from hormone therapy, maybe it's just hedging bets, but I often look at where they lie on that the inflection point on that curve in terms of risk of metastasis, and will certainly have a much lower bar to intensify local therapy, certainly in somebody who's declining hormone therapy. And I wonder if that's your practice as well. Do you use Decipher to help guide you in terms of intensity of local therapy?
Yeah, I would say I'm not the best person in the sense that I don't do, when I talk about intensification of local therapy, I mean, I guess there's two ways, right? One is, with brachytherapy, the other is, focal boosting. I sort of routinely, if it's like a safe area, do focal boosts often anyways, or I do a whole lot of just prostate SBRT where it's sort of the jury's still out if you need to focal boost, but trials are sort of deep underway. But I sort of have come out, and that's a whole other topic that I'm just not the biggest combination. I'm a big fan of brachy mono, and I'm a big fan of external beam, however you do it, but the combination of the two, just not the biggest fan of. So I'm just not the wrong person, but there are plenty of people I've talked to that do exactly what you do, that if it's, intermediate, whatever the prognostic system is, that may tip them over to treatment intensify.
What about on the opposite end of the spectrum? So we see gentlemen with high-risk disease who are not classic very high risk by NCCN and certainly don't meet the Stampede criteria, but do have extraordinarily high genomic risk. And my feeling is that those men probably do derive benefit from intensification of androgen deprivation, a secondary androgen agent. Have you moved secondary androgen agents into men in the high-risk population with very high-risk deciphers without the classic Stampede or NCCN very high-risk criteria?
Yeah, so I would say rarely, and so and that's sort of the point of that NRG 009 trial is what I find most sort of slam dunk with prognostic biomarkers is avoiding over treatment, right? Because it's saying that if I can get a really good estimate that your risk of whatever the endpoint you're looking at is so low that adding another treatment on top of it is going to be futile. It's not going to really derive meaningful benefit. What's more challenging is that, and sometimes like a medical oncologist always told me this, that, and it's probably more relevant in advanced, metastatic cancers, but having a bad cancer, like a bad actor, bad biology, you don't want to punish the patient for having it, because you can throw right in some cancers. Let's just take, for extreme examples, a GBM. You could throw 100 chemos, all the radiation you want, and it may do nothing, but it writes in a gray, angry tumor. And so that's where it's always a little bit, I try to see maybe a little more conservative, that I don't know if, let's say in those patients that are high grade, they don't meet Stampede criteria, but a high decipher, I don't know. I mean, maybe abiraterone, any of those drugs may help, or maybe they need something different. And that's just sort of where I think the jury's a little out, because I just don't know treatment intensification, what will help them. And that's similar with what I don't know is like an intermediate risk. If you had a raging high decipher score, which is predicting metastatic potential, the jury's sort of out, like, do you local treatment intensify, or is it that they may already have micromets and you need to already and systemic intensify? So I just don't know what the right treatment is, but I think you're probably I'm hoping, so there's two trials that have been done. One's called, besides the ongoing NRG trial, there's a trial called Atlas, which is in high-risk prostate cancer, sort of not as high risk as Stampede, radiation with 2 years of ADT plus minus apalutamide. They have profiled the whole trial with Decipher, and it hasn't reported out yet. So hopefully in the next year or so, we'll get that data. And I wouldn't be shocked at all if what you're proposing is correct, because that's my guess of what it's gonna show. But in general, I would say these are more of a slam dunk to me, where I feel very comfortable de-escalating treatment, sometimes intensifying treatment. So if that helps.
Yeah, and I, in that, to close out that thought, I looked at the PEACE trial data that early versus delayed, essentially addition of layering of therapies may have some impact, and take some solace in that for my very high risk guys, that maybe some of these secondary androgen agents might be worth it. To follow up on the notion of prognostic futility, I wonder if there is a patient who otherwise would be a candidate for radiotherapy, who has biochemical failure after prostatectomy, no evidence of metastatic disease, but with a constellation of adverse features like PSA velocity being quite high, although PSA number is absolutely low, with a very high Decipher score. Would you omit radiotherapy and in somebody who you otherwise would think is a candidate just because the genomic classifier and some of the other features are telling you that the risk of metastasis is so extraordinarily large?
Yeah, I would say that there's few circumstances, in a setting where there's, and I think if you look, right, the Stampede trial of, treatment of the primary sort of rocks a lot of people's worlds, right? Because in a patient with overt metastatic disease, giving a moderate dose of radiation improves survival, that clearly not eradicating all disease can still have benefit. And so I think that it still would be like if they got a PSA of 0.4 and it's sort of rapidly rising, the Decipher, right, it's metastatic potential. Like it may have already metastasized, but there's some great data and there's some more coming out with PSMA PET and Decipher, the correlation, and that patients with high Decipher are substantially more likely to have positive nodes on PSMA PET when you get it than at the same PSA level a lower Decipher. So there's some interplay there. So I would still, what I sort of do as a patient with a low PSA, the Decipher to me is what guides actually if I add ADT. And typically if I add ADT, I add nodal radiation. I get a lot of PSMA PETs now that it's FDA approved. But if a guy has a low Decipher in the biochemical recurrent setting, I would say rarely do I add, based on the data we published, any ADT or nodal radiation therapy.
We talked about local intensification, and I wonder your thoughts on regional intensification. Would you use a genomic classifier to change your nodal volumes to go higher, or to have a lower threshold to add in a nodal field?
Yeah, in the post-op setting, I would, just because the sport data, and actually that's underway. These things, I wish they, sometime I'd love to just someone write a book on the decade, like how long it takes to get an application through it's called CTEP, like the NCI, to get agreements and money to profile these trial samples. But yeah, we're going to profile the sport trial to better understand. But yeah, I'll add nodal radiation for guys with high Decipher in the post-op setting. I'm still sort of, the jury's out for me in the localized setting, because I don't know, nodal radiation to me, yes, we have the POP-RT trial, and I know Fidang Murthy, we're actually working with him to get access to his trial, but I don't know. I have a feeling we may be, when RTOG 0924 comes out, which is like a 2,500 patient trial, maybe it'll report out in like 6 years. My gut is telling me that we probably, at least in the way that it can select patients, I think 9413, I think technically is a negative trial, and I think 0924, if it's negative, I'm just not sure who the right person to add nodal radiation therapy to is in the intact setting. And POP-RT is kind of the only signal we have, which sort of primarily use PSMA PET selection. I did see a chat question. Does a high Decipher score correlate with a young age? So what's interesting is it's actually the opposite. So, a lot of cancers, right, young age, like in breast cancer, typically younger age is more unfavorable biology in general. In prostate cancer, actually older age has biologically on average more aggressive disease. And if you look back at that RTOG 9408 trial, what I tell people is that, of course, the older you are, the more likely you're going to die of something else, like a heart attack. But actually, they have higher rates of dying of prostate cancer. And if you look at the PROTECT trial, that trial of surgery versus radiation versus active monitoring, it was like almost all the guys who died on the active monitoring arm of prostate cancer, not of other causes, were the guys over 65. And a nice study done with a Decipher registry by someone, not myself, was that on average, older men had higher Decipher scores, matched to other things. So it doesn't seem the young age has borne out. Now, mind you, there's probably not a massive repository of like 40-year-olds with Decipher testing. So maybe it's a bimodal, like a U-shaped distribution. But in general, it seems, if anything, it's skewed towards older patients.
To close out our discussion about various stage and management, in the oligometastatic setting, would you consider genomic risk in terms of candidacy or not for focal therapy?
Yeah, this is one of the things that I think that a lot, especially the medical oncology community, struggles with, is that, right, they have validation, right, in multiple metastatic hormone sensitive trials, and it works. Like, I mean, it blows my mind, right, that you have a patient with metastatic disease in a piece of the primary tissue, like it's, from a biopsy or a surgery of their primary, is prognosticating their outcomes when they have mets or this, castrate-resistant disease. It's kind of mind-boggling, but I haven't yet figured out just how best to operationalize that. And I think it's just because we've got so many unanswered questions, like what is the role of ADT with, like the STOMP and ORIOL trials of metastasis-directed therapy. Like, there's just a lot of open questions. So I am not sure, if you've got a high score, does that mean you just need systemic therapy intensification? Does it mean, it's futile to do metastasis-directed therapy? I'm hoping that, we're going to be launching shortly. We're bringing Stampede. It's going to be called Stampede 2. They're launching in the United Kingdom. It's like they had too many arms. And I'm very fortunate to bring it over here to the US and open it at a handful of sites. And, its next arm will be, systemic therapy, radiation to the primary, and randomized plus or minus treatment of the metastases. And we'll be getting a variety of correlative tests, including Decipher, and maybe that'll help us understand, which patients it is or is less beneficial for. And the question in the chat about, for prostate, I have not used the ctDNA, the minimal residual disease, things like that, in prostate specifically. I just don't know, because we rely so much on, seeing the image, right? And PSA correlates so well with visibility on PET, right? If you've got a PSA that's, we'll just call it 0.05, but you have ctDNA, a PET scan is going to be negative, because there's a limit of detection on PET to about 0.3 millimeters, 3 millimeters, 0.3 centimeters. And so PSA is just such a good biomarker for monitoring recurrence that other cancers obviously don't have PSA. So that's where I think it is more utility.
Perfect. Well, it looks like that is the last question that we had in the chat box. I guess I give you an opportunity, Dr. Spratt, Dr. Engelman, for any final thoughts for the group before we conclude.
No, I mean,
I'll go first and just say thank you again for the excellent review, and that we are very similar in our practice patterns, using absolute benefit and patients' capacity for risk to try to avoid over treatment. And look forward to the future in terms of better selecting therapies for men who are still have a large unmet need. But thank you again for the great review.
Yeah, no, thank you. It's great to hear your perspective. It sounds like you guys are doing, definitely on the forefront. It's great to hear. And thank you guys so much. It's an honor to speak to y'all. Feel free, if my email is just daniel.spratt@uhhospitals.org, or I'm sure you can find on Google. Feel free if you got questions. I do my best. My email gets abused sometimes, but do my best. But thank you again. True honor to speak to you.
Fantastic. And thanks to our audience for being here. As a reminder, we were recording today, so we'll make it available to the ACRO membership for you to download and utilize in the future. And thanks to Decipher for helping put together today's program as well. So thank you, Dr. Spratt. Thank you, Dr. Engelman. And with that, we can be adjourned.